What interested you in this field to begin with?
I knew early on that I was interested in ophthalmology. Glaucoma, I didn't realize I was interested in until a little later on in my training. It wasn't until I began to rotate through and see the glaucoma patients and understand that these are patients that you're going to establish a great relationship with. They're going to be with you for your entire career, basically. You're seeing them multiple times a year. You're going through their ups and downs with them. And that's one of the reasons I got into medicine to begin with. So it fit nicely with that. The other reason is I think glaucoma it's a field that's still growing. There's so much opportunity in glaucoma right now in understanding what glaucoma is and how to better treat it, whether that's through medications, different routes of medications, different surgical techniques. It's so exciting to be in this field, and I think that really drew me to glaucoma. And then, of course, that you're having an impact in people's lives. Glaucoma is a disease that is potentially blinding. And if you catch it early and you intervene and you get them on treatment, you are really saving someone's sight. And that is huge. And that's one of the big reasons that I chose glaucoma.
Sure. And what has surprised you most about patients? I know in your practice you all learn a lot from patients.
Absolutely.
Any particular case that surprised you, perhaps in a good way?
Each person is a little bit different, and what I've gotten to know now in this year of being in my own practice versus in training, where you're seeing patients just maybe 1 or 2 times before you rotate to a different service, is you're seeing how glaucoma affects their life, how taking their drops every day, what the impact is on their life, whether they need surgery and how that has affected their life. And so getting to know that aspect of it has been very enlightening. And I think you get to know patients on a deeper level, and they grow to trust you, and you're able to work together a lot better when you have that kind of relationship.
And I would presume a lot of them are nervous about being here to begin with?
They are. It's an unknown. When someone finds out that they're coming to see me because of glaucoma, there's often a lot of questions. They don't really know what glaucoma is because it's hard to define. What they know of glaucoma is often very scary. They think they're going to go blind, that they're losing their vision immediately. And so a lot of the first visit is just talking with the patient and giving them a better understanding about what it is that we're dealing with, and really what to expect in the near future and the long-term future.
You're relatively new with the practice, so asking you about a particular patient, is probably premature because you're just beginning with a lot of them, right?
Oh, well, yes. I've had, there are some patients that, I'll speak about one who I saw this one was in training. I saw a lot of Haitian patients because I was in Miami, and they have a very early onset and very aggressive form of glaucoma. And some of these patients that I was seeing, they're in their 30s and their 40s, and they're already at end-stage glaucoma. So they're already at the level where they are legally blind from glaucoma. And I realized that in these patients, had we caught it early, had we been able to treat it earlier, they're in their most productive years here. They have families, they're supposed to be in the workforce, and now instead of working, they're having to have people care for them. And they're going to be like that for the rest of their life, the next 30, 40, 50 years. And so that really has motivated me to realize that something else needs to be done, and that goes back to this fund. And I think that's one of the reasons it's so very important, because we have to get to people earlier, get them access to treatment, and we have to keep pushing to get better and better treatments so that we can prevent people like this from losing their vision.
And what's the biggest obstacle for people becoming aware of glaucoma?
The hardest thing is that there are no symptoms that we can tell people to look out for. In most cases, they don't feel any pain. You don't notice any vision loss. It's your peripheral vision that's affected first. So it's not until the very end stage of glaucoma that you ever have any visual acuity loss where you can't read the eye chart as well. So there's nothing that the patient would notice that would prompt them to come into their eye doctor. And the other obstacle is that there's no one great screening test. We can't just check an eye pressure and tell you if you have glaucoma or not. It really requires a whole battery of testing and then putting the whole picture together to determine if you have glaucoma or not. So it's a time-intensive, labor-intensive. You have to have the equipment and the personnel in order to do that. And on a large scale, ultimately we would love to have a better screening test, something that would say, yes, you have glaucoma, or no, you don't, and be able to get those patients a lot earlier and into the right treatment. We just don't have it yet.
For sure. And in your young career, can you think of a moment you're most proud of?
I think for glaucoma, especially glaucoma surgeons, when we have a successful surgical outcome, it's very rewarding. I've taken patients who've been on 4+ medications, and they're getting worse. And when I perform a surgery, whether it's putting a tube shunt or doing one of the procedures that was developed here, the gap procedure or trabeculectomy, and I'm able to get their pressure controlled without drops, I mean, that they are so thankful and so grateful, and that's why we do this. That right there is why I do this, and so.
Wow, Kirsten, that's a great answer. Mm-hmm. Kirsten, did we want to add another question?
Tearing up at the very beginning.
Yeah.
Dr. Butler, when you see a patient for the first time in the exam room, and let's say it's an older patient, like how important is it for you to impress upon them to have the rest of the family checked out?
Yeah, so there's absolutely a genetic component to glaucoma, and that's one thing a lot of people are worried about, and some of them don't come out and say it right away, is that, did I give this to my children? Are they going to have to be checked? And the answer is, yes, they should be checked. Just because your parents or your aunt has glaucoma doesn't mean that you do, but there is a higher chance that you do. And so by all means, direct family members of those with glaucoma should be screened. They should have regular eye exams. That way, if anything does develop, it's caught early.
Great, good question. Kirsten always asks good questions. Your last two answers are fantastic. So you've been a great interview. Is there anything you wanted to say that we haven't given you a chance to say about the fund, the need for research? What you're most proud of? Want to make sure we're not missing anything that you think is important.
Well, I think that this practice is in a unique place with the people that we have here, the patients that we see, to do this. We see the need both in the local community, nationally, internationally, that there needs to be better access to care. We know there needs to be more research. We know where the research needs to be. In this practice, they pioneered a new procedure, which is just phenomenal. It's very, very exciting. We're so hopeful that this can help many, many people, but we have to be able to get it out there. We have to be able to educate the patients, educate the other doctors to learn how to do it. And this fund is going to be the key that's going to allow us to better care for glaucoma, which I think glaucoma affects, the patient who has it, but the whole community. If you have someone who is visually impaired, then it's not just them that's affected. It's their family, it's the community. And we're just really, really excited about the opportunities that this
thing. The worst thing you can do is ask somebody a question, giving them credit for something, and they say, "Well, I don't do that." you got to go next door. So the first time you did that, and the patient was helped. Share that experience. Take us to that time and place.
Oh, it was so exciting. So the new procedure, which it was developed here before I started here, but quickly they taught it to me quickly, and I was very excited to learn it. It's an angle, what we call an angle-based procedure, where it's opening up the natural drain of the eye instead of some of the other surgeries, which are giving you external drains. You're creating new drains. This is working with your own drain, making it work a little bit better. And we're all kind of glaucoma geeks. To work into that, get into that space and just see it in the eye was exciting to start with. Then when you actually do the surgery and you open it up and you see the flow, you see the fluid leaving the eye, and that pressure is going to be lower. I mean, that is in itself in the operating room was very exciting. Then to see your patient on the first day, 1 week after surgery, a month after surgery, 6 months after surgery, and they're still doing well, their pressure has dropped, their ortho medications are maybe need just 1 or 2 drops to control it. I'm still excited about it. It still makes me smile when I see those patients.
And it takes remarkable precision from what I've seen.
It is. It's a very delicate surgery. But it's one that I think physiologically it makes sense. You're opening up the meshwork, which is thought to be one of the places of resistance, and you're taking away that resistance. And so, it's a delicate surgery, but it can be very effective.
And it seems that it's remarkably simple in concept, although not easy.
That's true. There was a bit of a learning curve. But it is. I mean, you're taking someone's drain. You're not leaving them with any additional hardware in the eye. You're opening up their own drain, allowing it to function more effectively. In glaucoma, although pressure is not the definition of glaucoma, glaucoma is a change in the optic nerve. Pressure is a key role in it, and it's how we treat all forms of glaucoma. We lower the eye pressure. That's the one risk factor that we can control. And so by opening up their drain and lowering their pressure, you're in effect treating the glaucoma. And it's a very simple way of addressing the problem. Glaucoma is never a problem of making too much fluid. It's always a drain issue. And so you're getting at the root of the problem.
And I'm going to change that's a fantastic answer. That was a great answer. I'm going to get an additional camera angle.
Okay.
When that patient learned that they no longer had to use drops, just take us back to that moment again after you performed the surgery and you knew it was successful and you saw the patient. What happened?
Oh, these are patients who have oftentimes been on drops for years. So this is something that they have struggled with. You have to get into this routine of taking your drops. The drops, they are very effective. They're all many people need, but they also have side effects. Anything you do all has side effects. They can make your eyes very dry. They can make your eyes red. You can even get some systemic side effects from some of our drops. So by taking those away, people's eyes feel better. They're so happy not to have to use drops. Now, of course, we're always continuing to monitor these patients. With any glaucoma surgery, you still have to monitor them. I always tell them there's still a chance we may need a drop or 2 in the future. We have to keep doing the visual fields, keep doing your pictures, but if you can give them some relief. And not only that, also from a financial standpoint, drops aren't cheap. Any medication isn't cheap. And then you're talking about patients who are on multiple systemic medications and drops. They're getting to the donut hole. And if you can lessen that burden, even by 1 drop, that's significant on people who have fixed income and are really having to watch, how much of their money is going towards prescription drops and medications. You don't get that in other places.
What is it about the setup and the practice that just makes you so excited?
It's the people. It's the people that have worked to create this, and I mean it goes all the way back to I think how John Lynn, who started it, and his mentality, and it's focused on the patient care, providing good quality care, but also creating this camaraderie that when you have a group of physicians, it's easy to sometimes just do your own thing. They've worked really hard over the years, and we are truly a group and a family. And we share each other's patients. If we have a question, we bring in the group. If we have a difficult patient, we bring in all the minds together, and we really work together. And so that sort of collaboration is not easy to come by, and you have to have people that work well together, that get along well, and each person brings a little bit of something different to the table, and it really works out.
Sorry, was it rolling? Let's start again. About the expense of the medication, yeah.
In your training, it often doesn't come up, the financial impact that the different medications and treatments have. But when you're talking about glaucoma, you're talking about someone who's going to be on treatment for the rest of their life. And these drops are can be very expensive, and it can be very frustrating. You know, some of them have generic, some of them don't. Sometimes they go to the pharmacy, they get one generic, and they go to the pharmacy the next month and it's a different one. And sometimes the bottles are difficult to squeeze. They get more than one drop, or they're have to put 2 drops in their eye because they think they missed the first one, and they end up running out of drop early. They have to buy a second bottle before the month is over. These are the real life issues that patients face day in and day out that I hear about, and it's very frustrating to them, and it's very frustrating to me that I'm putting a financial burden on them to basically, if they don't use their drops, they're putting themselves at risk for losing their vision. But by using their drops and having to pay all this money, they're having to sacrifice something else that they could be putting their money towards. So it's a very tough situation, and I think it's just a reality of the healthcare system today. And if this fund can do anything to help with that, I know we will.
Great, Kirsten. That's a good question. Speaking of drops, who is the master of how to put drops in? Are you able to give a quick tutorial?
Yeah, so the way that I typically tell patients to do is if they have someone to assist them, that can be easy. If they're just trying to do it themselves, if they're laying down on the bed or the couch, that can be helpful. Have them grab their lower lid and look up, and if they can instill a drop in their when they're pulling their lower eyelid down, that's great. I often tell people to close their eye for a few seconds after they put the drop in. That's going to help keep the drop around the surface of the eye longer. When you're blinking, you're forcing the eye down the tear duct, and it's clearing, it's getting into the systemic circulation a little faster. So by closing the eye, or even putting a little pressure right here at the tear duct,
like
can
here?
help. Exactly.
Show
exactly.
us again. Right in
right
there.
here.
Okay.
Right here.
Okay.
Holding pressure after you apply and still your drops.
And if you miss a drop, the sooner you can get the drop in, the better.
Absolutely. And
if you're on international time, it's still, as long as you approximate the schedule, it should be okay?
Exactly. So if you're on some of our drops are just once a day, you want it to be as close as you can to 24 hours apart. So it doesn't necessarily have to be if it's, before you go to bed here to before you go to bed there. If you can stay on a 24-hour schedule, that's good. If you're a few hours late, that's okay. I'd rather you get the drop in if you say you forget, and then you remember, right before you went to bed, and then you wake up. Oh, I forgot my drop. Go ahead and get it in. But the easiest thing to do is kind of get into a routine, get into a habit. Put your drops by your nightstand or by your toothbrush, and do it at that point, or when you're taking your other medications, if you're doing it morning and evenings, or with meals. A lot of people can associate with the meals. Oh, it's breakfast time. I need to put in my breakfast drops. So we just have to kind of get it into the routine to help people remember. And people are using their phones nowadays too, setting alarms on their phones, which has been very helpful.
And you mentioned brand versus generic. Did you want to make a point about that? Are generics okay, or should they call the practice and ask?
Generics, I often start with generics. Generics have the same active ingredient, and so they are much more affordable and can give you good results. Some drops do not have generic formulations yet, and you're on brand name. And then there are other times when the generic just may not be working as well, because each eye is a little bit different, and just because one drop works well for someone doesn't mean it's going to work well for the next patient. And really, it's the journey that you go on with each patient, finding the right combination of drops for them that's important, whether that's generic or brand name, or a once-a-day drop or a twice-a-day drop or 3-time-a-day drop. Really, each person is going to be different, and it's my job to tailor the therapy to that person.
Wonderful. You are so articulate. Is he amazing?